Welcome to the Gist on Stat News Global. I'm Ramananda Gupta. Today we're going to be talking about urban health. And the two guests that I have with me are Dr. Indrani Gupta, who runs the Health Policy Research Unit of the Institute of Economic Growth in New Delhi and has held senior roles in the Indian government as well as with the World Bank. And we also have Alok Kumar Singh, a research associate at the Center for Social and Economic Progress, whose interests are rather, scientifically named, I suppose, include health systems, social epidemiology, the interaction of biomedical medicines with other medical systems. Did I get that right?
Yeah,
Okay, great.
that's
And
correct.
the two of them are co-authors of a 30-page paper titled Urban Health Falling Through the Cracks, published by the CSEP. Thank you so very much for joining us today. I'm really grateful. I look forward to an interesting conversation.
Thank you.
Um,
Thank you for inviting us.
Thank you. Yeah.
Let me start with Dr. Gupta. Dr. Gupta, from what I could understand, I've not really been able to go through the entire paper word by word, but um, there are specific reasons why you wanted to focus on urban health as opposed to, rural health, which seems to be, or at least appears to be the main focus of the government at most times. Could you just quickly give us a small bulleted kind of introduction as to why you decided on this? What made you think about doing this?
Thank you. So, historically, we have been focusing on rural health because obviously, after independence, rural areas were very backward, and all of the problems associated with backward areas were kind of seen as rural problems.
Right?
So, rightly, our focus was therefore on rural India and health being one of the major areas that we focus on. But over the years, what has happened is that the urban population has gone up very rapidly. And we have a large, and especially because we have a large denominator, even a percentage like 30% is a huge number in terms of people. And the focus did not appropriately shift from rural to urban when it's supposed to.
Mm-hmm.
So it's not that you do not focus on rural anymore, but you add urban as another area that needs equal attention. So our interest was that, as health sector people, we look to see whether Indians and or all our citizens have affordable, available, accessible healthcare that they
Mm-hmm.
need, and whether the health outcomes are equitable. So from that angle, we have done a similar paper, another paper where we look at health inequities,
Oh,
outcomes,
yes,
and
I remember reading that. I remember seeing that. I
so
haven't read it yet.
right. So we find that there are significant inequities within urban areas and within rural and urban, and sometimes the urban areas are looking much worse than the rural areas. So this
Mm-hmm.
paper, and that is especially for the urban poor. So this
Right.
paper is basically trying to make the point that it's about time that we started looking at urban population, and the COVID pandemic was a big wake up call because it
Mm-hmm.
happened mostly in the urban areas. We realized how bad the urban healthcare system was and how
Okay.
ill-equipped we were to deal with it.
I'll come back to you for a deep dive on that part later. But, Singh, um, when we try to differentiate between urban and rural, are there also, forget the services, are there differences in the kind of ailments that you see? Are there lifestyle diseases more predominant in the urban areas and not so much in the rural areas? Or are there differences in the kind of ailments you see in these two areas?
Ma'am can actually, if we can interject in between, but as far as we have seen, the ailment, the burden of disease in amongst the urban poor is higher than the rural poor that we have seen in our another paper in urban inequities.
Mm-hmm.
Um, so, in terms of lifestyle, you are saying overall disease burden we have seen, and it is much higher for urban poor as compared to rural poor.
Mm-hmm. That's again a very, very interesting, fact. I don't think too many people know about that. But would you attribute this sort of, extra disease due to lifestyle issues, or is it something else,
So if I
ma'am?
can just come in here, there has been this hypothesis that non-communicable diseases do not really strike rural areas, but that's not true. So rural residents as well as urban residents have now been seeing a lot of increase in the non-communicable diseases. So, but the focus in policies in the urban areas for non-communicable diseases has been rather low, because even the in the NHM, which is National Health Mission, the NRHM and now
Right.
NHM, there has been separate focus given to, let's say, lifestyle diseases. But we can come to that point later in the under the NUHM, the National Urban Health Mission, etc. There
Right.
are policies on paper, but those have yet to be operationalized in any significant way. So
Mhm.
urban areas are seeing all kinds of diseases. So they are seeing non-communicable, but they are also seeing a lot of the very rural type of water sanitation related diseases as well, because of the
Okay.
habitation that urban poor people live in. So I think the
Right.
main focus of this paper is also to bring to everybody's notice that when we say urban areas, we can't only talk about the well-to-do urban residents.
Of course not.
We need to actually look at the areas that are completely deprived of water, sanitation, habitation, good houses, etc. Because those impact on your health outcomes.
Hmm. Now, when we also talk about urban and rural, when we talk about the divide, uh, I was reading somewhere that, despite the government having made uh, or having built aims in almost every state capital, most people from all these states, whoever can afford it, come to Delhi. I mean, is that something that buttresses your claim that there is a problem with just setting up? You can't just set up a thing, but you need to fund it. You need to have good doctors, and you need to have specialists involved. Is that the issue here?
That the issue is actually the missing primary care. You see, what is happening is
Hmm.
that healthcare should be basically, we see three tiers, right? Primary, secondary, and tertiary care. Now, all
Right.
these, like hospitals, they do offer primary care, so don't get me wrong, but they're mostly focused on tertiary care, hospital based care.
Got
Now,
it.
what's happening is that when you have malaria or fever or TB or any of those things, you first need to go to a primary care physician, the nearest one,
Hmm.
and that has to be nearest to your home. If that
Hmm.
is missing, which is actually missing in urban areas quite a bit, rural areas have a structure. They have primary health centers,
Right.
secondary, and etc. But that structure has been missing in most parts of the country for urban health. And so, what is happening is people bypass, they have to bypass because there isn't anything. They bypass primary care facilities and go straight to the tertiary care facilities. So, there is overburdening. And
Hmm.
as you rightly pointed out, the finances for urban health has been very low. It's not enough to
Hmm.
just fund a hospital with some
Right.
money, but you have to get, see how much clients, how many patients to come, and it doesn't match
Hmm.
that number. But Alok, you may
Okay.
want to add something here.
Sure.
Yeah, in addition to that, what we also have found is that there are uh, fragmentations in the structure, administration, and governance in the urban health. And
Hmm.
when we say fragmentation, basically there are various programs run by various ministries, and even within the Ministry of Health and Family Welfare, there are multiple programs targeting same population with different financing, different source of financing. So that is, I think, one of the major problems that we have highlighted in our paper that needs to be addressed in order to address the urban health.
Hmm. One of the things I loved about your paper is that, unlike just listing out the problems, you actually offer solutions. Everybody has a laundry list of problems, but not too many are willing to actually offer solutions. So I really like that about your report. But if you were to look at the thing holistically, what do you think would be the first thing that the government should sort of tackle to solve this problem?
Well,
Or maybe a
there are
list of two, three things that the government should immediately do.
there can't be just see, the problems of urban health are many, and all of those need to be addressed. The first is, and they often don't remain in the health sector, they spill over
Hmm.
in other sectors. One is the
Absolutely.
Definition of urban is very important to fix, because different authorities are dealing with different kinds of urban population. So
Right.
as Alok rightly pointed out, this fragmentation is one of the main reasons why urban health, we are not having a holistic approach towards urban health, because there are so many authorities, they don't talk to each other. So if you
Right.
say urban health, it sounds as though there's one monolithic thing, but it isn't. So that's
Hmm.
one part. So there has to be, and there has to be consistency in definitions also. Sometimes the definitions
Right.
are not consistent. So that's one part of it. The other is there is no apex body that actually, I think urban health, it's about high time that urban health comes under an umbrella of one
Hmm.
authority, and that has to be multisectoral, because water, sanitation, housing, all these things are equally important for urban health, because they impact the outcomes. So if you have lesser outcomes, you will have lesser burden on your health facilities. So
Hmm.
maybe an ethics body can be set up that looks at urban health in a very holistic fashion, and enlists
Hmm.
all these other departments and ministries as well
Hmm.
under umbrella. And
That's
there has to be a blueprint of how we approach urban health, which has not
mhm.
been done, frankly.
It's like, I assume I could say that it's like building a toilet and then not having a pipeline for the water, for the sewage.
Yeah, exactly, exactly,
You know,
exactly.
so I mean, but Singh, how would you actually build a body like this when I'm hearing that there's already confusion over what is my scope as an urban area? I mean, if that keeps fluctuating, the authority or whatever authority you put in is going to be perpetually sort of, in a flux, wouldn't it? Unless the borders between urban and rural are very, very clearly defined. From what I'm hearing, they're pretty blurred at the moment. Um, wouldn't it be difficult for any administration to work like that? I mean, I'm sure that that would be one of the challenges if you were to look at it.
No, but if I may
Yes,
It's
please.
a
say a
question
few
for you,
things. Yeah.
Alok. Yeah.
So it's not like we haven't actually experimented with that. So NHM is one example where actually we tried to establish one umbrella organization, and it's just an example I'm giving, that
Hmm.
government has actually experimented with creating one apex body that could look after the funding and administration of programs. So NHM was actually a holistic sectoral reform where it actually brought vertical programs under one umbrella body, and then also decentralization of funding. So similar kind of approach, I mean, not similar, but I'm saying that we have experimented, and it's not that we can't do
You
that.
can use that as a pointer or a guideline to see what
Yeah,
worked, what didn't
yeah,
work.
something
Hmm.
like that. Yeah, I mean,
Okay, but
If I may
the
just
vision in mind.
interject,
I'm sorry.
yeah, no, I mean
Please,
that
please.
exactly. So if you could replicate the NRHM thing for NUHM,
Hmm.
the remaining one important part of that is financing. Even in NHM, total NHM financing has also been going down. So
That's
now
right.
the situation is that we are health allocations have been pitifully low, as you know, in India. So whether it's
Hmm.
NRHM, NUHM, or NHM, it really doesn't matter. It's not sufficient for the number of people we are catering to. So
Absolutely.
as Alok said, so not only the apex body, but you also need to finance the apex body and give the responsibilities. And the one missing picture has been the local bodies. For instance, the local bodies have no
Hmm.
funds. So urban health is urban local bodies have to be empowered, and if they're not empowered, they have to be empowered administratively. They have to be empowered financially and politically. So in every way, the local bodies have to be empowered, because they are closest to the people that their clients. So I think that has to happen when you set up the apex body. So it's not only one step. There are many things that you have to do.
Hmm. You'll forgive my ignorance, but healthcare would be on the concurrent list, right? Or is it on the
no,
state
no, it's a
list?
state subject. It's a state subject. It's a health is a state subject.
Yeah.
Oh, okay. So some have it on the concurrent and some have it on the state list.
Some
Good.
It's
Okay.
a
So
state.
right away that division comes in of one hand not knowing what the other hand is doing in some ways. You will not be able to centrally administer a law in any of across the country. Is that what I'm hearing?
No, I mean,
No, so yeah, so state has been a state. Health is essentially a state subject, but the history of policy making, health policy making in India has been like, center has been actually taking a role of policy making and providing a guidelines for the state to actually implement those policies. But
Hmm.
what we have seen is that the poorer states like Bihar, UP has been highly dependent on the central funding for implementation of these programs. And similar
Right.
thing what we have highlighted in our paper also, that municipal bodies, local bodies are actually highly dependent on the central funding for the implementation of
Hmm.
programs. And that's why you see there, the problem is that the capacity itself is low for both the state and as well as the municipal bodies, especially the municipal bodies, I would say.
Hmm.
yeah, and also what has happened in many of the earlier functions have been taken over by the center. So what
Right.
the center has a lot to do with how the states are functioning. So whilst health is a state subject and the states are responsible for running many of the programs, there are many central programs for which the states are dependent on the central funds. So
Right.
if those funds are not transferred in time, or they don't come, or they're low, this it really impacts on how the states function in the health sector. And then the third tier is absolutely not given, funds, and they are completely dependent on the state government for transfer of funds to their to the local bodies. So it is a complex system.
Hmm.
So while it is a state subject, there is somehow there is a lot of center
Of course,
dependence.
all these aims and everything are all central things, right?
Yeah.
So that, I mean, in many ways, it's a good idea, but I don't know whether you should have started it without being able to fund the whole thing, because each of these things would be a very expensive process. It's not just building a building. I mean, equipment itself must be a fortune, and then getting trained doctors.
Especially because if your resource envelope is constant and you keep on building new aims, then you have that
Absolutely, I
much
agree.
less money
I
for other
agree.
activities, right? So had it
Yeah.
been a that's being pushed outwards and then you're investing on names, then that's great. But on a
Hmm.
constant resource envelope, if you keep giving more and more to one kind of health service, then you're obviously neglecting primary care, etc. So in the new Ayushman Bharat nomenclature, there is health and wellness center, which is supposed to be primary and secondary care revamping.
That's right. Yes.
Look at the finances for them also, it's very low, and it's not easy to find to beef up the primary care with that low funding.
Hmm. But yeah, at the same time, I once had the fortune of trying to do a paper on exactly what you're saying, that, how effective are these primary healthcare centers, particularly in Punjab. And I was quite impressed by the sort of, enthusiasm which is shown by all these paramedical kind of people who can't even issue a prescription. They can basically just give you initial. I mean, that just as an aside, it's there, it's a problem. But I found that, the people who work there to be a lot more enthusiastic than I thought they would be about what they were doing. It's almost like a cause. So one looks for hope where one can, I suppose. Um, Mr. Singh, I have a strange question to ask you. You've studied the interaction of what is it that you said? Biomedicine with other medical systems and things like that. Post the pandemic, the government must have learned a lot of it. Hopefully, learned a lot of lessons on how to be prepared for all this. Would there be a call for that kind of a system to be in place across the country? Somebody should understand how it works. What does it do? What
That
I'm
kind of system,
understanding about, you know, you're trying to see whether these two things contradict each other, or if there's a problem. I mean, in one not working well with the other. Is that what I'm right?
so you are asking biomedicine and the health service system, two system you are
Yes.
saying, or
Yes.
so no, health service system essentially works on the principle of biomedicine. The question is basically the what I have studied or what I have seen during my dissertation is that
Hmm.
I mean, especially in the poorer states, there are lots of informal provider that work, and the dependency on informal
Absolutely.
provider is very high.
Some of them are witch
Uh,
doctors.
Yeah, I mean, because so we have talked in our paper also. In this, I think in the next paper also, we have talked about the density of health services, primary
Hmm.
health centers and sub centers,
I'll look
and
forward to that.
you will see that the density of health centers, both in rural and urban areas, but in urban areas especially, is very low actually. So what happens is that your health center is not near to the household, and because the
Hmm.
health center is not near to the household, the dependency of household on informal provider is more than the government health system, and that is causing actually a lot of other problems. So we have highlighted this in our other paper also, that there is need to actually increase the density and also strengthen your organizational structure, so that the problem of accessibility to health service system should be strengthened.
Hmm. Dr. Gupta, among the two solutions that you propose, one is, of course, streamlining the entire system so that there's a, one knows exactly where one needs to go for whatever issues that you have. And the other is, of course, funding. Were there any other sort of, findings that you had while researching for this paper which startled even you, that you weren't expecting that kind of a thing? Were there what were the other sort of interesting findings from your research while doing this paper?
Well, on the other paper, the twin paper, as I think, let's
Hmm.
call it, we were thinking that maybe the urban poor are not doing very well. But I think it is still surprising, not surprising, but it drives home this point that the rural poor sometimes are doing better than the urban poor. And that kind of tells you that we really need to act now rather than later, because again I would say that it is rural areas are much more homogeneous in various ways, and urban areas
Hmm.
are extremely heterogeneous in every way possible, administratively,
Right.
politically, everything. So if we continue to not focus on the urban areas and urban health, we would
Hmm.
see, we know that urban health population would only grow, it cannot
Right.
shrink. We are going to actually see a lot more problems in the years to come. And
Hmm.
the main thing is that primary care in urban areas, I think, is really missing at this point, and it needs to be extremely well endowed administratively and financially, which is not happening. And
Huh?
therefore, this whole bypassing of the referral, there is no referral system. The referral system does not work. It doesn't work
Right.
very well in rural areas, but at least there's some semblance of it's working. But in urban
Hmm.
areas, so everybody is depending on private providers, and you know that the private sector is completely unregulated in India. So the
Hmm.
outcomes are varied and iniquitous. There is out of pocket expenditure on the poor, and they're doing much worse financially. There is no health coverage. The health coverage for the new PMJ, that is the Prime Minister's Jan Arogya Yojana, is a
Right.
hospitalization scheme. It does not cater to primary service. It doesn't cover primary services. So what is
Hmm.
happening is that with, and that you saw in the pandemic also. So when you have fever, you all illnesses do not result in hospitalization, right? You can prevent
Right.
hospitalization with giving primary care, and that's not happening in urban areas. I think it's happening
Hmm.
much less in urban areas to me, compared to rural areas, because in many rural areas things have improved quite a bit. So I think the time to act is now, frankly,
Hmm.
and focus. And two things have to happen together: the administrative focus on urban health and the financial focus on urban health. They have to come together. You can't do one after the other, because every time you reorganize a sector, there are finances involved. So you have to do it together simultaneously.
I've always found it to be extremely sad that at this day and age, we still have women dying of anemia during childbirth. We still have children stunted and things like that. And from what little I've understood, a lot of it has to do with social norms, which politicians obviously don't want to get into. As in, the woman in the family eats after everybody else has eaten. She's basically, a childbearing person. So you get her married off and then she can stay. I mean, she's seen as a burden and all that stuff. Maybe it's been changing. Does that change that social norms when somebody moves from a rural area to an urban area? or does it remain there for a generation and then moves,
So
or
this
does
is
it
not
not
a.
move at all?
So you're just asking a general question about norms,
General
social.
question, because something that I feel very embarrassed about, that how is it that with so many programs, so many things, you still have women dying of anemia simply because some social norm says that
Of course.
they're
I
not
mean, I
important enough.
yeah, I don't think that families carry their cultures and their norms when they migrate. I don't think that they
Hmm.
necessarily change. However, suppose you migrate from rural to urban areas and your finances are such that everybody has to work and women start working. So, the empowerment comes slowly and the norms
Hmm.
change slowly. So in the beginning, the norms would be the same. So you have to put your ghungat in, and you can't work, and all of that. But the urban
Hmm.
reality is strike, and children have to go to school. The girl has to go take a bus. All of that also happens. So they probably
Absolutely.
do change, but they change with a lag. And but they do change. I think. I mean, I wouldn't say that
Maybe a generation or two down the line, the whole thing changes.
yeah, the norms do
Mm.
change, but that is a separate point from the fact that people are still dying of anemia and all of that. That is, I think, generally there is poverty, so there is
Hmm.
nutrient intake is very different, very low. You're not really looking at
No,
what you're eating.
but I thought there was enough government support for that. You had actually deep down in the rural areas saying that
No, I
a
don't
woman
think
brings
so.
this must have that.
No.
No.
What I have observed during my dissertation in Odisha is I just give you example. So people in BPL families, they actually get ration from PDS shops. So when I
Right.
asked them that, how long this, you this ration goes, and
Hmm.
they said that, it hardly goes for 15 days. So even though they
Oh,
are getting ration for 1 month, it gets consumed in 15 days, and sometimes if the guests are coming, it gets consumed in 7 or 8 days. So
of course.
the PDS, and so if I include PDS plus ICDS ration, the supplementary food for the pregnant and lactating mothers, that combined is not sufficient. When you What I have seen in the rural areas of especially is not
Hmm.
sufficient actually for the women and the children to actually get nutrition, and that's why the recent NFHS data shows that the anemia among women and children has increased. One of the determinants is, of course, the insufficiency in the nutrition intake, and the government programs, I think, is not sufficient, I believe. Yeah.
Hmm. So what I'm hearing is that a lot of the lessons that we perhaps could have learned from the pandemic are not really being studied and worked upon, because immediately after the pandemic, India became a sort of a symbol for the way they're supposed to have vaccinated so many zillions of people overnight, and we actually exported vaccines. But I mean, we all saw pandemic too. That it didn't sound like what the government is telling us, but that's a different thing. All these shortfalls that were detected, you know, during the pandemic, when the government had to sort of hustle to get this work done, what do you think would be the most first thing that the government should tackle to ensure that, or I mean, have they done that?
So, Mr. Sengupta, if you look at the
Yes.
rural health
Hmm.
statistics is a Ministry of Health and Family Welfare publication, right? It
Hmm.
brings out the shortfalls in infrastructure and personnel, and we'll
Right.
be shocked to see how severe the shortfalls are in our country in many of the states, especially the EAG states, the empowered action group states, that are the vulnerable states, right?
Hmm.
Now, shortfall in doctors, in nurses, in assistants that you need, and chemists, all of that,
Hmm.
and shortfall in infrastructure. So actually, the buildings are not there. So the government has these norms, right? That you are supposed to have this many people, these
Absolutely.
many.
Yes.
So those are all there are severe shortfalls. Not all states, but many states. Even the
Hmm.
well-to-do states have shortfalls in districts.
Right.
So when the pandemic struck us, we were scampering around for hospitals, for PPP, that gear, for gloves,
Right.
for everything was short, and we saw the oxygen shortage as well. I mean, whether we want to believe it or not, we all know that we saw it. Now, I would differ a bit, saying that we did very well in tackling the pandemic. I wouldn't really say that. I mean, we lost many months.
No,
See, even
I didn't say that either. I was just trying to
no, no, I mean, you can
say.
say that, but a lot of people do say
Mhm.
that,
Right.
look how you managed to do that. But,
Hmm.
even one death is death too many. Why should we let anyway? So even if you delete
Absolutely.
the whole thing for 3, 4, 5, we were importing finally from China and other places, consumables,
Hmm.
health, disposable stuff, etc. Why? Why could we not do it ourselves? So we knew that there were shortfalls because the rural health statistics brings this report out very regularly. It's not that the government didn't know that. We have just not prioritized the health sector, and the prioritizing by prioritizing, I really literally mean that, like other countries who are supposedly on the path of universal health coverage, 5, 7, 8% of their GDP is being put into health. So if you don't
Hmm.
put that, obviously your health facilities are not well stocked, and
Right.
therefore when a pandemic breaks out, there are
Hmm.
many countries in Europe that have such excellent primary care that they dealt with the pandemic, though deaths happened everywhere. But they could deal with the pandemic at the primary care level mostly and then send the severe cases to hospitalization
Hmm.
hospitals. But that didn't really happen in India. And we also don't know the total number of casualties, by the way. There is some
Of
controversy
course.
there. Yeah.
That's
So,
it's a massive number. But
yeah, I
we've
look,
all seen. I mean, sorry,
sorry,
you
I
wanted
thought
to
I
say
looked
something?
something.
I was just saying that we've also seen both the waves, as they call it, of the pandemic. The first one, where which came, I was quite impressed with, particularly with how the Delhi government reacted, and they put down. The second one was a disaster, of course, with no oxygen and all that. But suppose and let me ask this to both of you, given that you've already had one experience, and not just us, the whole world has suffered from that. Um, I'm sure there's likely to be another pandemic anytime. You can't predict it, but well, do you think we are ready for it in urban areas, not just in the rural areas? I sometimes suspect that rural areas would probably be better off in a pandemic than the urban areas, because simply because of the density of population, I suppose. But even otherwise, are we ready for the next pandemic? Which is not a question of if but when.
Alok, you
I
want?
mean,
I mean,
What we have shown in our paper and the findings of our paper, both paper, no, this and the coming paper, shows that
mm-hmm,
our health system is not resilient enough to actually handle those kind of health shocks anywhere in the near future, because there are so many huge shortfalls at multiple levels, at the
mm-hmm,
HR level, at the physical infrastructure level, and the medical equipments and everything, diagnostics. We have shown that there are shortfalls at the national level, and and that is impacting the health outcomes severely. So I believe at the current stage, with the current pace and with the financing, as we have already said, that there is a very low financing. We don't see that the current healthcare system is resilient enough to actually handle any of the health shocks in the
I'll
future.
interrupt for a second. You meant low financing. When you say low financing, are you talking about financing the entire project, or are you talking about, let's say, financing distribution system, or infrastructure or something like that?
So two things. One is the overall health financing as percent of GDP currently stands at what World Bank shows it is around 1.1%, excluding capital expenditure. And
Hmm.
the municipal financing also, that we have shown in our paper, that municipal financing is very low. As you see, it's around municipal owned revenue is around 0.4% of total GDP. And with the coming of GST, you have seen that the
Yeah,
financing has further declined at the local
of
level. So
course.
both at the local level and the national level, we don't see the sufficient financing to the health system. And yeah.
yeah,
What
and if
about
I may,
research?
uh, I just want
What
to
about research? Hmm.
add to that thing that Alok just said. You see, there were three budgets after the pandemic, health
Hmm.
budgets, and I mean total budget,
Right.
but health budget did not show any increase whatsoever. We all expected, given the experience of the pandemic, we would have seen a huge jump. Huge, though
Of
there
course.
was no jump. There was no jump at all. In fact, if
Hmm.
anything, there have been declines in some important areas like NHM, etc. So, as Alok
Hmm.
said, I don't see you can't build a resilient health system without financing. And this is total financing of all parts of the health systems, whether it's primary care,
Right.
secondary care, tertiary, research. surveillance, all of that is being financed with this 1.1 or 1.3% of GDP. Cannot
Mm-hmm.
happen. It's possible. States, because it's a state subject, states have to then raise much more revenue if they have to match, the problems. They are not being able to do that either. So
Mm-hmm.
I think we are not quite prepared for the next. There have been some changes. I think
Mm-hmm.
we have ramped up some production in some consumables and all of that. So those are good things that have happened. We also have to see that there are other ministries that are dealing with parts of it, like there could be the gloves, etc., are probably happening in some other ministry.
Yes.
So all of that also needs to be looked at. But the basic health care is still the Ministry of Health and Family Welfare's baby, which is
Mm-hmm.
primary care, secondary care, tertiary care, infrastructure, personnel, drugs and medicines, all of that. And we don't see changes in the finances. So it's going to be a bit
I do hope the people who matter, who can actually make these changes, are going to be listening to this recording. But on that note, I'm sorry, I'll have to close this interview because we've run out of time. I thank you both very, very much for taking time out. I'm really grateful. And I look forward to having you again.
Yeah, sure. Thank you. Yeah.
That was Dr. Indrani Gupta and Alok Kumar Singh talking to us about urban health and whether or not we are prepared for the next pandemic. I do hope you enjoyed this particular episode of The Gist. Don't forget to like, share, and subscribe. Till we meet again, this is Ramananda Sengupta signing out.